Thank you. So we're now going to turn to the next part of the session, unique problems in multinational studies, regional perspectives on endpoints and outcomes. We're going to let all three speakers present, and then essentially at the end of the presentations ask them all to come up and sit with us and answer your questions. So please write down any questions you may have, as we'd like to have a vigorous discussion. I'm going to hand it over to Brendan to introduce.
Thank you, Nick. So we're going to hear from Dr. Kobayakawa, who's a specialist in gastroenterology and hepatology. He's conducted approval reviews for the application of new drugs in Japan, such as remocitron for IBS-D and proton pump inhibitors for non-erosive esophageal reflux disease. He served as the assistant chief in the Clinical Research Management Office at the National Center for Global Health and Medicine, and as a reviewer and external expert at the Pharmaceuticals and Medical Devices Agency, or the PMDA, in 2004. Thank you for coming.
Thank you. Good morning, everybody. It's my great pleasure to give a presentation at this meeting. This presentation doesn't represent Pharmaceuticals and Medical Devices Agency, PMDA, official opinion or policy. I'm going to give this presentation from my experience of review. Oh, no. Sorry. From my experience of review for approving new drugs in PMDA and the aspect of regulatory science, as well as a clinician of gastroenterology. This reading is NCGM left. It's my hospital. I usually working at this hospital, but I review of drug application once a week in PMDA. Light building. Please remember the name of PMDA. It's a Japanese regulatory authority. First, I'll talk about ethnic differences. ICH, International Comprehensive Harmonization, E5 guideline describes ethnic factors in the acceptability of following clinical data. There are many intrinsic and extrinsic ethnic factors that influence the efficacy and safety profile of drugs. It's necessary for global studies to use medical and diagnostic definitions that are acceptable to all regions and utilize endpoints that are considered appropriate for assessment of treatment. And this slide shows classification of intrinsic and extrinsic ethnic factors described in ICH E5 guideline. Intrinsic ethnic factors include genetic factors and physiological and pathological conditions, such as gender, race, genetic polymorphism of the drug metabolism, height, body weight, ADME, receptor sensitivity, age, liver, kidney, cardiovascular functions. And extrinsic ethnic factor is environmental factor, in other words. For example, culture, socioeconomic factors, education status, language, medical practice, and smoking, alcohol, food habits, and so on. I think especially these three extrinsic factors, language, medical practice, food habits, could influence the efficacy and safety of medicines and the risk and benefit assessment in different populations in IBS. Ministry of Health, Labor and Welfare in Japan announced basic principles on global clinical trials for promoting global studies in order to resolve drug lag. Its circumstances where drugs approved in US and EU are not approved in Japan and cannot be provided to nations, and clearing up the questionable points to consider for conducting global clinical trials from the perspective of a review for regulatory approval. And this slide shows a flowchart for determining whether or not a global clinical trial should be performed. The question in the dotted boxes in this chart show issues that may be also confirmed by other results. The judgment whether or not there is an important difference or effect should be made, taking into consideration the design of the clinical studies, the comparison between populations, and the other relevant factors. But there would be many exceptions, and no universal approach exists. So it would be appropriate to determine conduct of global trials on case-by-case basis. As you know, Rome criteria was defined first in 1988 and revised twice in 1999 and 2006. I think the new diagnostic criteria are neither sufficiently established, nor sufficiently reliable, nor sufficiently validated. And this is our latest diagnostic criterion for IBS, the Rome 3. The duration of disease must be at least 6 months prior to diagnosis. The disease is characterized by stool conditions, as indicated in this slide. However, there are no need for result of blood test, endoscopic examination, or stool culture test. I think this criterion is more clinical definition rather than scientific definition. The frequency of symptoms with participants who are eligible in clinical trials are at least 2 days a week, but those with IBS patients other than clinical trials participants are at least only 3 days per month. I think it would be difficult to expand result of clinical trials to all IBS populations defined by this Rome 3 criterion. In Japan, almost all Japanese are under public medical insurance scheme. Patients can easily consult a doctor and undergo endoscopic examination less expensively. For example, many patients consult doctors within 3 months after onset. A patient pays only $70 for conventional colonoscopy. So, I think criterion fulfilled for the last 3 months with symptom onset at least 6 months prior to diagnosis might be basically inappropriate in Japan. Even if inclusion criteria were the same, the participant characteristics would be different between Japan and other countries. Food habits are also different between Japan and other countries. Japanese eat rice and a lot of fish and vegetables. Japanese traditional food is low fat and high salt, and there are many soy foods such as miso soup, soy sauce, or tofu. On the other hand, Western people eat bread and a lot of meat. Western traditional food is high fat and low salt compared with Japanese traditional foods, and there are many milk products. The language is one of the most important problems. For example, there are a lot of terms indicating pain in English. I examined these 4 words, cramp, gripe, colic, bellyache, from Japanese English dictionary. I can't understand the differences among these words. There are also a lot of terms, mimetic words indicating pain in Japanese. Discomfort is very vague. There may be some differences between Japanese patients and other countries' patients, and even among Japanese patients. Next, I'll talk about primary endpoint for IBS clinical trials. The Rome 3 recommends global weighting scale of change in symptom intensity by patient, such as adequate relief, satisfactory relief, subject global assessment of relief. I think they can be interpretable by patient. There may be Hearing problem among regions compared with integrative assessment. In addition, they are considered a kind of QOL. But there are some problems. It's not clear whether a patient's stool frequency, abdominal pain, or discomfort are improved or not. Patient baseline and the current severity of symptoms cannot be evaluated. Patients have to record their conditions over a period of weeks or months. it could be said they are not objective endpoints. They are very important problems in conducting clinical trials and assessing for effect of medicines. So, I think another co-primary objective endpoint is necessary. It must explain pharmacological mechanisms and indicate the improvement of abdominal disorders such as stool frequency or stool form. It should be evaluated for the efficacy of new drug together with global rating scale of change in symptom intensity. Regarding multinational study, it could be meaningful to evaluate the efficacy on the same basis of criteria and the endpoint. But the extrinsic ethnic factors between Japan and Western countries have major impacts, as I mentioned before. Let me show you the flow chart of basic principles on global clinical trial again. We approved ramosetorone, serotonin receptor antagonist for IBS-D in Japan before. So I'll explain this flow chart by using ramosetorone. Ramosetorone has no correlation in pharmacokinetics and efficacy. Pharmacokinetics is even different between Japanese men and women. So it goes to no. Ramosetorone, a primary endpoint of ramosetorone study is patient global assessment, and it's not objective endpoint. And extrinsic factors such as language, clinical practice, and medical insurance scheme has major impact, so it goes to no. Eventually, additional domestic study is necessary. In Europe and North America, it might be possible to conduct a global phase 2 and phase 3 study, but I think it would be difficult for Japan to conduct a global study with other countries, even with Asian countries. There are fewer intrinsic ethnic factors which affect efficacy and safety profile of drugs in Asian countries. But as for extrinsic ethnic factors, language and medical practice are also different. Moreover, IBS might be contaminated with IBS-like bacterial or parasite infection disease in Asian countries. In conclusion, a domestic confirmatory phase 3 trial should be separately performed in Japan regarding the application of new drugs for IBS. Thank you.